what do you put those things on there for?
Why?
Yeah.
We want to monitor the electrical activity of your heart, and that can tell us a lot of things about what's happening in the other parts of your body and how your heart's doing.
Cora Anderson is no stranger to the operating room. She's had several serious health problems, including a lung transplant and a knee replacement. This time, she has an aneurysm in her brain.
I know it's a time bomb, and I know that it has doubled in size, and it's very threatening.
An aneurysm is a ballooning out of a blood vessel wall. The larger the aneurysm, the higher the risk of rupture. And when a cerebral aneurysm bleeds, the result can be catastrophic.
If you have a large bleed, your outcomes are going to be much worse. So if you treat these aneurysms before they've ruptured, it's always a better outcome.
Patients may experience few warning signs before a brain aneurysm ruptures.
Unfortunately, there are no symptoms specific to aneurysms. Temporary loss of vision, temporary loss of hearing, double vision, weakness or numbness on any side of the body. These are all general symptoms for all the strokes. Things that are very specific to aneurysms are if the person were to get what we call the worst headache of your life.
Cora is one of a few million Americans walking around with aneurysms. As many as 30,000 a year actually rupture. The patients who survive the bleeding and patients with unruptured aneurysms have similar options for treatment.
There's two treatments available to treat aneurysms these days. The one is the classical go inside, open the craniotomy and do a microsurgical clipping. And the other is the endovascular coiling. We take a catheter up through the groin, go into the aneurysm and coil it. There's the vessel, there's the vessel. We're going to keep that, we're going to visualize that in 3D so we can just keep everything above. As long as we everything above there, we're going to be safe.
Cora's doctor, Gavin Britz, is co-director of the UW Medicine Brain Aneurysm Center at Harborview Medical Center.
This is a larger one. We want to fill up the spaces and not have something go through the steps.
They treat as many as 300 aneurysms a year.
And that's one of the highest volumes in the country. And the best part about this place is we have specialization in each of the different techniques we can use to treat these aneurysms. The endovascular approach, we have the best team. We have some of the greatest surgeons who do direct clipping of these aneurysms. And also, we have one of our team members who's trained in both, so that gives him a unique perspective to decide which treatment may be suited for a patient. And again, there are a lot of studies which show that the more cases you treat, the better you get at it.
So I'm comfortable now that that is not in the vessel lumen, but is in the aneurysm itself. Many neurosurgeons probably see 1 or 2 aneurysms a year. You know, I treat that in the first 2 days of the week.
Dr. Britz is a genius. I mean, the guy is just a genius. He's very compassionate. I had the opportunity to have his shoulder to actually cry on, and he was there to hand me a tissue and say, "It's okay. It's going to be all right."
Cora's multiple health problems, as well as the size and shape of her aneurysm, had to be considered when deciding on treatment. Dr. Britz is qualified to do either a surgical or an endovascular procedure.
I'm a dual-trained neurosurgeon, meaning that I am certified as both to do the microsurgical clipping as well as certified to do the endovascular coiling. There's patient factors and aneurysm factors when I make the decision. So patient factors that are important would be age of the patient, medical problems, and then the aneurysm factors would be the specific factors such as the aneurysm location, the size of the aneurysm, and then you make the decision based on those factors. I'd put at least 3 or 4 more cords inside, but I don't want to push it.
Both procedures are effective for treatment of many aneurysms, but not all. By which I mean you cannot coil every single aneurysm. Coiling depends on 2 major factors. One is that the aneurysm, which is shaped like a ball, has to have a neck, which is the orifice through which the blood enters. If the neck is narrow, that the coils stay inside nicely, and then we can coil it. If the neck is broad, then the coils get washed out, you know. One way of preventing that and helping that is by placing a stent across the base of the neck, which can be done, but again, not in all patients. There's no way to coil this one.
At Harborview, treatment decisions are often made jointly by the team. Dr. Shaker, Dr. Britz, and Dr. Godke.
Don't you think it's a good idea, Raj?
We put our heads together, and this is very critical because each one brings a very, very special expertise to the table. Raj, for instance, is perhaps the most experienced and expert neurointerventional radiologist that I know. Gavin Britz is dual trained. I'm in training for endovascular, but I bring with it, very special skills in terms of surgery. So we all, put our heads together and decide what's best for the patient.
Cora's case was complicated, as radiologist Brian Cott showed us in this three-dimensional image of her aneurysm.
But you can see here this aneurysm is extremely large, extremely complex, and it's involving a large portion of this internal carotid artery to where there really isn't a definable or discernible neck of the aneurysm that we think in the traditional sense.
Endovascular coiling was chosen to treat Cora Anderson, but because of her aneurysm's shape, a neuriform stent like this one was needed to make the procedure work.
Ideally, this would have been treated surgically. The problem with the surgical approach for her would be that all the other medical issues would make it very complicated and probably not worth the risk. A new treatment is now available for these broad-based aneurysms called a neuriform stent, and what we go inside then form a trellis around the vessel, and then we can treat it.
Cora was involved in discussing treatment choices, but for her it was a very simple decision.
And I would like you to live some more. So let's go in and get it taken care of.
This is what the coiling procedure looks like. Dr. Raj Godke is Director of Interventional Neuroradiology for the UW Medicine Brain Aneurysm Center at Harborview.
We put a small needle into the groin, put a small catheter up to your about 6 inches inside, and then through that we put this tube, which is about 3 millimeters wide, and this goes all the way through the aorta. And instead of going down towards the heart, we go up into the carotid arteries. So this catheter right now is going to be in the carotid, and through that we're going to put a small microcatheter up into the aneurysm. And then through that catheter, we're going to deploy what is called as platinum coils. And these are small wires made of platinum, very soft, and we end up filling up this area, which looks like a blister on the vessel called the aneurysm, and plug it from the inside so that the risk of bleeding goes away. And everything is flushed. There is saline infusions going between all the catheters to reduce friction. And then the catheters are advanced under fluoroscopy. So we have a screen where under X-rays we can actually see the catheters and wires traveling. We have what is called as a road map, where this whole angiogram is superimposed on our fluoroscopy. So we can see exactly where we're going. And we can navigate through all the twists and turns of these vessels.
Cora Anderson had a neuriform stent put in place during an earlier procedure.
Now this stent usually goes across the neck of an aneurysm to help us keep the coils inside and prevent them from coming out.
So you can't hold it without a stent? No, there's no ways.
And I think this is the perfect treatment for her.
Mm-hmm. Some people go inside and put the stent and the coil at the same time, and it can be done. But as in my experience, when you do that, I think your complication rate is slightly higher because the neuriform stent hasn't settled in the wall yet, and this is more movable. So what I did with Cora is I got the angiogram first, and then went inside the 1 week and placed the neuriform stent, and then brought it back the following week, and then just coiled it through the stent. So this is going to be the last coil because of a kidney function, okay? And I'm happy. It looks very good. 5 years ago, we were coiling less than 10% of the aneurysms, and now we're coiling about 2/3 of the aneurysms here at Harborview. I think the technology's got better. Our microcatheters are better. Our coiling is, the material we use to coil the aneurysms are better. And I think as things are going to evolve, it's going to shift the curve even further towards coiling. The endovascular route is still new, and there's still huge advancements that can be made that's going to make it safer and more effective and durable long term.
It's looking very good.
Yeah, I think it's looking very good as well. Raj, I think it looks good. And I think the neuriform stent has just given us such a nice... And I think I'm extremely happy with the result. I couldn't wish for a better result. It looks great.
I like that thing. That is really the best find I've ever made in ornaments.
And next to my favorite Santa Claus.
Next to your Santa Claus, yeah.
John and Roxie Phillips moved from San Diego to Washington State to be closer to their children and grandchildren.
That Santa Claus is old, it's 100 years old.
One of their first connections here was Dr. Lalagam Shaker. because Roxie has had a brain aneurysm for several years. The first sign was a violent headache as it ruptured.
She nearly died after that hemorrhage. This was not here. She was in San Diego at that time. But she recovered to the point that she could be treated, and she was treated by using endovascular coiling method, which is the right thing for her age and location. At the time, she had a complete right third nerve paralysis, which indicates that she has no movement of the right eye. She had had a couple of strokes, either as a result of the hemorrhage or vasospasm, which follows after this type of hemorrhage. But she recovered from all of that. The problem, however, was that she would get an angiogram every year, and the coils were compacted or pushed into the aneurysm, so the aneurysm had reopened. So each year she had to have more coils put into the aneurysm.
I had a total of 5. I had one every year except 2001. I had 99, 2000, 2002, 2003, 2004, and I was getting pretty tired of having procedures.
The coiling procedures weren't working as a long-term solution, but clipping an aneurysm is very difficult after coils have been placed inside. Roxie's age and the location of her aneurysm were also concerns.
The location of the aneurysm is the most difficult area for neurosurgeons to deal with. So because of that, I had to do a very, very special operation. The idea was to take the radial artery from the forearm and connect it as a graft from the right middle cerebral artery to the posterior cerebral artery, which is one of the vessels that comes off near the aneurysm. And with that as protection, then clip the aneurysm or close off the artery bearing the aneurysm.
Dr. Shaker pioneered this technique and was the first to perform it in Seattle. Before offering the procedure to Roxie, he discussed it with the team.
So surgically, what we could do here is to either consider or do clipping of the aneurysm itself if the neck is favorable, or do distal basilar occlusion. But in order to do that safely, we need to put a bypass into the right posterior cerebral artery so that she has good collateral flow through that. So what do you think about that option?
I think it's a great option, especially because the major limitations are her tortuosity of her vessels. Her vessels being so loopy, it prevents us from doing the right optimal treatment with catheters.
She seems to be a very vigorous individual in good health, and she really wants to live and wants to continue to have a quality of life. And she's aware that this is a very dangerous situation for her with the aneurysm reopening like this. So she wants to have something done.
He had 2 different options that he offered. I don't remember what they were exactly. But I liked the one with the bypass. It made better sense. And also, it looked like it might be a long-term solution.
This way, she's got a good chance of a perfect life for years and years after she does this. And there's always a lot of worry involved, and I am certainly worried about it, but I'm also very upbeat about it. And I think she is too. I want criticism, if there is any, about the cookies. Oh, come on, Rox, those are better than anybody else could make.
John and Roxie have been married for almost 50 years. They laugh at the same things, and the success of her surgery is equally important to both.
How many pies have you made in your life? 2. I thought so. I thought exactly so. Well, one of these days, something may slip. May, as a result of the surgery you're going to do, you'll wake up afterwards and you'll have a great desire to make pies all the time. Do you suppose that happens?
Then I'm not going to have the surgery.
You're not going to do it?
No, not if I'm going to wake up and bake pies.
Roxana, I brought Dr. Shaker, honey.
Hi, good morning. Good morning. How you doing? I'm doing fine.
Okay, all the tests came out well. So we're all set to go.
Oh,
Do you have
good.
any questions?
No, I don't think so. We're all set, ready to go?
Patients are naturally nervous when they come in for surgery, and they're particularly nervous when they're coming for something as major as intracranial surgery. I mean, it's totally understandable. I think the best part that we can do to allay anxiety is really to explain to the patient what is going to happen, what we're going to do to the patient.
Dr. Shaker said I should go shortly.
Yeah, that's what he said.
So what time is it?
It is now just 7:25, so
7:25, okay.
yeah, it should be pretty quick.
So,
As with Cora Anderson, there's an entire team involved in Roxie Phillips' care during her stay at Harborview.
In particular, myself, Dr. Raj Godke, and Dr. Gavin Britz, we have a very good relationship and understanding of each other and each other's goals and aspirations. To this team, then we bring in anesthesia, for instance, Dr. Lamb, neurophysiology monitoring, OR nursing, and then intensive care nursing and critical care specialists, and we have radiology technicians and so forth. So all of these people, it becomes a critical mass.
Right where it comes in?
Right where it comes in.
Oh, I see, okay.
I worked in many places in the country, and I would say that at Harborview, we have probably one of the best teams that I've ever seen, in all my life. And it's a 24/7 can-do hospital. That means patient comes in and you say, I need an MRI, I need an angiogram. They say, yes, doctor, it's done. So this is particularly suited for treatment of aneurysms and stroke, because aneurysm and stroke happen 24/7. I mean, they're not things that can wait. This team process is extremely important, and there is an ongoing process of discussion amongst neurosurgery, stroke neurology, anesthesia, critical care, and so on, which facilitates everything.
Okay, Roxanne, are you ready? We're about to put you to sleep now, okay? You're gonna slowly drift out to sleep. Think about something nice.
Think of a nice place to go.
What differentiates the neuroanesthesiologist from a regular anesthesiologist is the interest and a better understanding of the pathophysiology of the brain and what are the special requirements for intracranial surgical procedure like the one we're discussing today. And there are specific surgical demands that require special knowledge to provide the optimal conditions for the care of the patient. At a certain period of the surgical procedure, the patient is particularly placed at risk of cerebral ischemia or lack of blood flow to the brain. And that occurs when the surgeon has to put a temporary clip on the major feeding vessel to decrease the amount of blood flow to the aneurysm or allow him to do the bypass. And what we do is that we do two things. One, we monitor what's going on in the brain by way of doing evoked responses or electroencephalography. That is the brain wave that is normally generated by the brain. The other thing that we can do is to calm the brain down and actually decrease the amount of oxygen that the brain requires during these particular vulnerable times.
It's right there on the MRI. The aneurysm, and then on the CT scan, right here you can see the coils give you an artifact, a scatter artifact. That's what you see here. That's the coils. And on this 3D imaging, this is a 3D angio reconstruction. You can see that the coils are right there. And on just regular angiograms, you can see the coils right here. You see this ball of sort of silver-colored ball that's compacted. That's inside the dome of the aneurysm.
Part of Roxie's skull is removed to expose her brain for the surgery. Dr. Shaker takes part of an artery from her arm for the bypass.
Very nice radial artery here.
Both Roxie and Cora were at slightly higher risk for aneurysms because they're women. Age also contributes to developing an aneurysm, as well as some conditions such as polycystic disease of the kidneys. Not all aneurysms require treatment, especially if they're very small.
You just follow it up. If there is any dramatic increase in size, or if there are some symptoms which you think are caused by the aneurysm, then of course you'll think about a treatment. But there are a significant number of aneurysms which may be riskier to treat than to leave them alone.
Brain aneurysms are very distinct and different from aneurysms in the body elsewhere. So when we're talking about brain aneurysms, these are usually what we call saccular aneurysms. And these are weak areas, weak points, and very thin-walled structures. By and large, brain aneurysms are more difficult to treat because they're inside the head.
It's a challenging field to choose for a specialty.
A lot of intensity. I mean, that's the thing. It's the one thing about vascular and skull base is that it's always pressure. And there's not, there's some parts of surgery, regardless of the specialty, that you can just say routine cases, nothing's going to go wrong. People are always going to wake up fine. Problem with vascular is even if the operation sometimes goes perfectly, people can have complications.
So why did these doctors choose this specialty?
Personally, you want to make a difference, and these are some of the most high skill operations you could do, and you do make a difference. You're saving a lot of people's lives by preventing these from rupturing or preventing them from bleeding again. So it is kind of exciting to be in this field.
I've always wanted to do neurosurgery from, I think, age of 7, possibly related to my father's spinal cord injury. He had a motor vehicle accident when we were very young, and I was exposed to neurosurgeons and exposed there, and that just set the tone, and that's what I wanted to do from being a youngster. Vascular, I chose because I think it's still the most, that and skull base is still the most technically demanding part of neurosurgery, and most of us going to neurosurgery are competitive, ambitious people, and we like to do what's the most challenging to do, and that's what I like to do it, yeah.
That's certainly true in Roxie's case, especially the technique of bypassing the brain's blood vessels.
It is a technically difficult operation in terms of microsurgical skills. You do have to have extremely steady hands and very good hand-eye coordination, and you're working under the microscope in a deep space and so forth. And there are so many little details, not only of the operative techniques, but also anesthesia, nursing, angiography, all those things. The whole team is important.
The radial artery from Roxie's arm is sutured to the arteries in her brain, completing the bypass graft. Once that's done, her surgeon closes off the aneurysm with a titanium clip. It's a very delicate operation, made more difficult by the coils placed in the aneurysm during earlier procedures. When surgery is complete, Dr. Shaker calls for radiology to step in.
So what I've done is connect the graft from the MCA on the right to the right PCA.
Okay.
And then eventually I was able to actually clip the aneurysm. Initially, I put a clip on the distal basilar artery, but I was able to dissect and clip the neck. It was not very easy because the coil mass was really hard, and I could not see, I couldn't displace it enough to look behind, so I could only see it after the clip was sort of closing down. Yeah. And I think the left PCA is slightly kinked, but I could see all the perforators, they're okay. So I think you just need to, I think you probably need to do an intraop angio.
Okay. Yeah, well, we'll go ahead and shoot the right carotid and look at the graft.
Right.
It's the MCA to the P2, and then we'll come back and shoot the left vert.
Okay, great.
Vertebral artery.
Excellent. Okay.
The angiogram shows that the bypass and clipping procedures have been successful.
Okay, here's injection of the left vertebral artery, the basilar artery. This area up here is where the aneurysm was, and you can see here it's going to roll back again. You can see here on this injection there's no filling of contrast inside of where the aneurysm was, so it's been completely excluded by the clip. And the vessels that go on beyond the aneurysm are filling. Normally they're on the left side, and on the right side they're being filled a little bit from this side, but also primarily now from the graft that was placed that we saw on the other side.
Great. Okay. All done.
All right.
Thank you very much.
After surgery, Roxie appeared to have some complications.
3 days after the surgery, she developed symptoms of a stroke involving the right side of the brain, and she had left-sided weakness and not complete paralysis, but some speech difficulties. We did all the tests and nothing major was found, and she was treated with fluids and she got better.
Roxie's been working with the rehabilitation team at Harborview. John's been able to stay there with her, sharing a room and participating in her recovery.
How are you?
I'm fine. I'm reading my everyday food book.
Well, it's high time. It's high time.
I appreciated having him here. And I put him to work.
Yes, you did. Yeah, I've had plenty of instruction. Yeah, and the therapist put me to work. She puts me to work. The nurses put me to work. So.
Hello. How are you doing today?
Doing pretty well today.
Meanwhile, Roxie's doctor is happy with the results of her surgery.
How's the left arm coming? All the way.
Great.
Let's lift it up all. Good. Wiggly fingers. Excellent. Touch my finger. Good. All right. It's coming along pretty well. She is recovered almost back to where she was previously, and she is still improving. So I do expect that, she will be completely recovered from this procedure. The angiograms since that time have demonstrated that the aneurysm is now completely closed. The aneurysm is no longer seen, and the bypass has done its job.
For Roxie and John Phillips, it's a job very well done.
You like it?
Yep.
Well, I'll say the same thing I said Dr. Shaker, and that is that due to his skill and his abilities, this whole misery that's been hanging over Roxie's head for 6 years now is taken away. She is essentially cured of the problem and doesn't have to worry, is that going to get worse? Is it going to get into an incurable state? What's going to happen the next time I go back for a test? All of that is taken away, and she can just look on the, future with confidence, and that is worth an awful lot. Just an awful lot.